Oh, ok, dovremmo esserci. Setting up the people over here. Yes, okay. Ladies and gentlemen, welcome back. Today, we're going forward with the anatomical dissection. I'm very glad to have my brother Paolo Battaglia from Varese. Good morning, Paolo.
Good morning, Puya. Good morning to everybody.
So today, Paolo is going to talk about DCR first, then he's going for endoscopic orbital decompression, then he's going for rescue flap, and then small flaps for anterior skull base defects. Is it right?
Yeah, right. Before flaps, later on, yeah, about the same. It's only a question of timing.
For those who's interested, we are planning for next week probably another session just reserved for 2 or 1 flap, which is very interesting. Is the flap that Paolo developed a few years ago, and I was part of. I was delighted to be part of his work, and it seems getting huge results. So let's go ahead with your presentation strictly ahead.
Yeah, perfect. So I'll try to be. Here you are, perfect. I'll try to be direct to today's section without clinical cases. And let me please, just before starting, to thank my resident in Varese, mainly Giorgio Sileo and Rosio, that helped me in building up these videos. So it's a hard work, and it's not only my work, but is the Varese team work. Please, it was necessary to thank them. And so it's a part 2. We had some anatomical details on sinonasal spaces last time, so we will go directly to the second part. And the audience was quite interested last time in the rescue flap. It's very important to know this kind of flap or beginning of the flap, because it's very useful if you approach the cell or if you approach the sphenoid. Try to preserve the arteries that passes under the sphenoidal ostium, the septal branch of the sphenopalatine artery, because it's very important to preserve in order to build up the adult flap later on, and not to have the flap in front of you or stored in the rhinopharynx or the maxillary sinus. So if you need it, then you can use the adult flap performing the rescue flap, or you can use the rescue flap not only in order to build up the flap later on, but in order to drill the base of the sphenoid and to enlarge the ostium of the sphenoid without damaging the arteries. And who knows that in the future the patient will need to have skull base reconstruction or a pituitary tumor treatment. So in such a way we spare the arteries. As you can see, is the rescue flap is the beginning of the adult flap. So what it means is it means building, it means preserving the pedicle of the flap. Can you see the arrow when I move the arrow on the screen?
Everything is fine.
Okay, you can see the arrow also, okay. So here you can see the inferior turbinate. We are on the right side, inferior turbinate, the tail of the inferior turbinate and the choana. Here is the superior turbinate with the natural ostium of the sphenoid. You have to preserve this area between the tail of the superior turbinate and the tail of the inferior turbinate. So the inferior limit will be the superior part of the choana, and the inferior limit and the superior limit will be the inferior border of the sphenoidal ostium. So here we are, the rescue flap on the left side. So here we are on the left side. You can see here the choana, the Eustachian tube, and here is the superior border of the choana. Here we can see the tail of the middle turbinate up to here. You see the tail of the middle turbinate, and the inferior incision is just here just here at the level of the superior border of the choana. So from the tail of the middle turbinate down to the floor of the choana. Then up, what we can identify is the tail of the superior turbinate with the natural ostium of the sphenoid. So you have to identify this marker. You stay at the level of the superior turbinate and check. This is very important when you will build up this flap. You have later on to follow the tail of the superior turbinate, the inferior part of the superior turbinate. The most frequent mistake is to go straight and low. And this is the best way to damage the pedicle. So also when you build up the adult flap, this is the rule. You have to follow with your incision the border, a line parallel to the border of the inferior part of the superior turbinate. You see, you have to go up. In such a way, you can free the mucosa, the mucoperiosteum, and you can, in such a way, put low or up the pedicle, the rescue flap. If you put down, you can enlarge the sphenoidotopy medially, if you push down the mucoperiosteum, so you can enlarge superior and medially. If you put up, you can drill the basisphenoid. You can see you have the arteries inside this pedicle, and you can go below to get better access towards the upper part of the clivus, or you can go above and get access to the cavernous area or to the cellar supracellar area. So when you go inside, you can identify all the landmarks, but Jacopo Dallani yesterday gave you a beautiful lecture about the anatomy of the cella, so I will skip this information for those who participate to the last webinar. So this is the rescue flap. It's the beginning of the adult flap. When we started that flap, we start with the rescue flap. Okay, let's move to the next flap. That is the adult flap, is the most common flap that was used during the last 10 years at least, but 15 years perhaps is more correct. And as you can see here, you prepare the pedicle, but then you move anterior towards the in the septum in order to get more material you can to close the middle, the posterior, or the anterior cranial base. So as you can see here, starting, you see, we prepare yet here the rescue flap. You see, this is the superior turbinate, the middle turbinate, the tail of the middle turbinate, and here we perform this superior incision at the level of the natural ostium of the sphenoid that follows the tail of the superior turbinate. Okay? So, and then inferior, I showed you before the inferior incision. Then you can have an anterior incision. It depends, you can go anterior till the cutaneous tissues. It depends how long you need the flap. If you have to reconstruct the middle skull base, you can perform an incision also at the level of the axilla of the middle turbinate. If you need to cover the anterior skull base, you can arrive till the anterior part of the vestibule. And you see, we start posteriorly following the line of the inferior border of the superior turbinate. And then you have to take in mind later on, when you arrive at the level of the axilla of the superior turbinate, your second landmark is the axilla of the middle turbinate. So sphenoidal ostium following the inferior border of the superior turbinate till the axilla. Then when you arrive here, you put the scope anterior and you join the axilla of the superior turbinate projecting on the septum with the axilla of the middle turbinate projecting of the septum. So you can go till the axilla of the middle turbinate projecting at the level of the septum. So in such a way, you spare at least 1 centimeter in the upper part, and you reduce the risk of the hyposmia. That in this case is not a complication, but it's a possibility, it's a reality you can have after you perform an ADAT flap. But if you preserve this upper part of the mucosa, you decrease this risk. Then, when you arrive here, you see axilla of the middle turbinate. Here, there is an horizontal line towards the septum. Then you can go up till you want, so that you can enlarge the anterior part of your ADAT flap. So axilla and then up. You can arrive also here without problems. Then we use to dissect the mucoperiosteum, this time till the natural osteum of the sphenoid in such a way. So you have to detach the mucoperiosteum, and then you can choose how large you can you want your flap. If you need a large flap, you can extend the incision, the flap till the inferior meatus. So here you see we are detaching the mucoperiosteum from the floor of the nasal fossa. Here posteriorly there will be the choana with the posterior incision over there, and then dissecting here posteriorly, you can move laterally till the floor of the nasal fossa, and then you have to prolong the anterior incision laterally till the medial wall of the maxillary sinus. Your posterior limit is the junction between the hard palate with the soft palate. So the mistake, if you make this incision here posteriorly on the soft palate, so you prolong the incision of the rescue flap inferiorly, you see where the soft palate becomes hard palate, and you prolong your incision at the level of the inferior meatus. The anterior incision here till the medial wall maxillary sinus, and you have to pay attention only to one structure here on the medial wall, that is the Hasner valve here anteriorly. So don't prolong to hide anteriorly here in the inferior meatus, because the risky point is the Hasner valve that it's here. So then you connect the two horizontal lines inferiorly with the scissors, and now you need to free the ADAT posteriorly. So with these small scissors, you can, cut and free the pedicle of the flap. This is what we do. It's a joke, but it's only to say we perform exactly in this way this flap when we are with the neurosurgeons that don't help you. So you need to work with the scissors and to dissect before the nasoseptal flap, because if usually when the neurosurgeon removes the tumor, does not want to help you with the bleeding, so we don't use usually to make the incision, all the incision before and then perform the flap. But we have the anterior incision with the second periosteum. We go in a vascular place, and then with the scissor we can build up the flap with the sides that we need in such a way, with small scissors in such a way in a vascular plane. Of course, there are different techniques. You can use monopolar, or before making the dissection, make all the incision all around at the sites you need. But in such a way, you can build up the sides of the flap as you can. And you can see at the end, you can cover a huge amount of exposure. Mainly here, we did an approach to the cella. You see, it can cover the clivus, the cella, and also the pterygopalatine fossa of the contralateral side. But this is how to work. And this is a quite innovative technique in order to prevent the stenosis of the draft type 3. So we know that the success rate, mainly in phlogistic pathology of the draft type 3, when there are polyps, when there is a phlogosis inside the frontal sinus, the restenosis is very high. And we reduced this kind of restenosis rate, and also in European experiences, we have direct experience. We speak a lot of time during Congress with Herman or with the Barcelona group, Alobid, Bernard Spreckensen. They started to use these flaps, and of course there are small data we have put it together, but they seems really to increase the success rate of the draft 3 procedure for chronic phlogistic pathology. You see what means. We use to cover the borders of the draft 3 with 2 flaps. One flap, it's a random flap, and is built up from the lateral wall of the nasal fossa anterior to the axilla of the middle turbinate. And this random flap is at the level of the projection of the ascending process of the maxilla that extends toward the septum. This is used to cover the anterior border of the draft 3. And then on the contralateral side, we use a flap instead of pedicle at the level of the septal branch of the ethmoidal artery. And this flap will cover the posterior wall of the frontal sinus. I want to say one thing. This is not a surgery with the flaps for a fast and furious surgeon. You need time. If you want to have a fast surgery, is not the time to try to use the flap, because you need to be very careful and build it up. And sometimes with the drill, you have to take attention not to take the flap in the tip of the drill, because you will destroy the flap in 1 second. So let's schedule your surgery for 1 hour more. You planned without flaps. You need time and you need concentration. I'll try to show these flaps are not easy, but are very useful. So the random flap based on the lateral wall toward the septum, and the pedicle flap based on the anterior ethmoidal artery to cover the posterior wall of the draft 3. So this is a recent section that was focused on this building up of the flaps. So we have to perform the draft type 3. Before performing the draft type 3, you have to prepare your flaps. You cannot start directly as usually as I showed you the last time. So let's start from the right side. Right side, middle turbinate, axilla of the middle turbinate. Usually we trim the axilla of the middle turbinate. We trim the head of the middle turbinate, sorry for the mistake. We trim the axilla, and then the second things we do, pay attention please, is to check for the insertion of the middle turbinate at the level of the anterior skull base. So you have to open the agar nasi. You have to remove the anterior wall of the agar nasi. who follow my last lesson perfectly knows what Dehgani means. So let's see, you remove all the anterior wall of the Dehgani. And you arrive where? Here, exactly where the middle turbinate attaches at the level of the skull base. This is an important landmark because we know that at this level we have the insertion of the middle turbinate, we have the anterior ethmoidal artery coming out just precisely at this level. We have the first olfactory fiber just in this area. And we know that anterior to this part, we will have the floor of the frontal sinus. This is an important landmark. When you don't have any more landmarks in your surgery, and you have a middle turbinate left, you can use it in order to build up to start with your draft. So now we start with the random flap. The posterior incision, so towards the choana, is at the level of the insertion of the uncinate process on the lateral wall. The anterior incision is at the level of the maxillary line. So in this area, there will be the nasolacrimal duct. So it's the mucosa that covers the nasolacrimal duct and goes towards the ascending part of the maxilla. So it's very important to take in mind here where the uncinate process inserts. Here, anteriorly to the projection of the nasolacrimal duct. Then, you see, you can, in such a way, build up the lateral part of the flap. Then, like an horseshoe, you can prolong the anterior incision on the same line toward the septum. In such a way. And you can go down till the floor if you want. Okay, anterior incision over here. And then up, dissection. And then with the scissor, you arrive at the level of the posterior incision, parallel to the incision you did at the level of the lateral wall. And in such a way, you can preserve the passage from the lateral part of the flap towards the medial part on the septum. You see, we detach now all the mucosa here till the septal branch of the anterior ethmoidal artery. We have recomplete the posterior incision on the septum over there, and the posterior limit is the septal branch of the anterior ethmoidal artery. Now we can complete the flap here in the upper part. Okay? You see, the posterior part, the posterior limits is the insertion of the middle turbinate on the skull base. And so we free in such a way completely the flap. And we can put it down. We can put it down, the last cut. Okay. Now it's completely free. And we can store this flap in the middle meatus if you want. You can see middle meatus. And we leave there. So we remove, we use the flap anterior to the anterior ethmoidal artery. Then left side, we trim the middle turbinate, and again we want to see the attachment of the middle turbinate at the level of the skull base. So we remove the anterior wall of the Dehgani cell. Here is the attachment of the middle turbinate, and we know that there will be the septal branch of the anterior ethmoidal artery. you see? And you can perform a racket that is anterior, the anterior incision is anterior to the, I want to show, to the septal branch of the anterior ethmoidal artery. So attachment of the middle turbinate of the skull base, just make an incision anterior to this point and comes anterior. Okay, and then you come anterior and down. Then second landmark is the axilla of the superior turbinate. Axilla of the superior turbinate, at this level, you make the posterior incision of the flap, and then you come anterior. And you make this sort of rectangular flap that is pedicle at the level of the septal branch of the anterior ethmoidal artery. It takes time, I know, but at the end, it will cover with the vascularized flap the posterior wall of the draft. And then you can put this flap posteriorly. You see here, you complete the posterior incision parallel to the axilla of the superior turbinate. And this will be the base of your flap. And you can push the flap posteriorly, okay, and store there. Then, you see, and you store on at the level of the olfactory cleft posteriorly. And now, when you perform this kind of flaps, you need to remove the upper part of the septum at the level of the floor of the frontal sinus. And you can do it, you see, this is the upper part of the septum. This is the floor of the frontal sinus. You remove in such a way in order to perform the draft, and you have your landmarks that are the insertion, is very clear here. This is the insertion of the middle turbinate on the skull, the same on the left side, anterior ethmoidal artery, septal branch, anterior ethmoidal artery, septal branch. Or as we all know, we can drill anterior to this area and we will go direct inside the frontal sinus. So you have always to see these two arrows of the middle turbinate that goes towards the skull base and the two septal branches coming out. Now you can safely drill at the level of the floor of the frontal sinus. You drill, and now we went inside the frontal sinus. Okay. Skip a little bit here. So now we can enlarge laterally our draft type 3 on the left side and on the right side. We can drill the intrafrontal septum, and now we use the flaps in order to cover the borders of the draft. Okay, this is the left side flap, pedicle and anterior ethmoidal artery, that covers the posterior wall of the frontal sinus where we drilled. So we try to cover the bone that we drilled. You see here, pedicle, the pedicle, and let's check over here the random flap, pedicle on the lateral wall of the right nasal fossa, that we can, in such a way, you see, cover the anterior part of the draft till the contralateral part, you see? From the right side, it covers all the drill bone till the left side. If you have the time, if you want to try, they are very useful flaps in your armamentarium.
Paolo, can we stress the importance of during this unprecedented time, the importance of having the equipment to do surgical dissections to keep, you know, involved or trained, because we cannot perform surgery. So instead of doing that, we still have to do dissections.
Sure.
If you have your own lab, you can do it. In Varese, for example, the team has his own lab. They are proceeding, and this is the importance of having a lab for the students, because you have to train them, and the only way that you can continue to doing the teaching, this is the importance of having an anatomical lab.
The lab is fundamental. In the time of the lockdown in Varese, we organized 1 month dissection sessions where all the residents, all the colleagues that were interested in endoscopic sinus surgery dissected from 8 a.m. till 8 p.m. because we need images, we need to improve the surgical techniques. The only way is to have a field without blood. You have to try this kind of dissection of flaps before in cadavers, of course. And you need also to have a lab with all the instruments that you use in the live surgery. If you have only a cotton, a flare, huge flare, just to see the anatomy, is not easy to perform this kind of flaps. Of course, these flaps are recent, so we'll try to show these videos later on to the courses in Varese next times. Till 1 year ago, we didn't show these flaps, so we did this work in order to share with all the ENT that will come to Varese, or if they ask, they will give the video and they can do it in their own lab. But endoscopic surgery is something that can change and improve, and of course the lab and the dissection is what makes it possible.
Great. I'm sorry for interrupting you. Please go ahead.
Thank you, Puya. It's fundamental concept. And let's go on with, I have, 20 minutes. I think. So I don't want to lose time, but I cannot see no more. Okay. Then I will show other flaps in order to make the DCR. So also in this case, you can make a DCR with the drill. You can point the drill here and go direct inside towards the nasolacrimal sac. It's a way, sometimes it works, but if you want to make your result better, to make a more delicate and sophisticated DCR in order to increase the success rate, you can perform the flaps. And this flap will, all the flaps in this kind of surgery as the main target in order to cover the exposed drill bone. And so we perform usually this superior flap anterior to the axilla of the medial turbinate, exposing the anterior wall of the agar nasal. So here, you know, it's a flap based here superiorly, it's a random flap that it's anterior to the axilla of the medial turbinate over here. We expose the ascending parts of the maxilla just anterior to the agar nasal. And we store this small flap here at the level of the anterior part of the olfactory cleft. Then we can remove the bone anterior to the sac over here and drill the lateral wall of the agar nasal. That it means that is the medial wall of the sac. And we drill here in the superior part. We don't expose the duct. We want to expose the sac. So in such a way, we expose the medial wall of the sac and we open the frontal sinus. just to get a better view and all the landmarks in front of us. After this, you can see, we can also not to open the maxillary sinus. This is the mucosa that covers the inferior part of the uncinate process. You see here, we are pushing and we expose the medial wall of the sac. Here, uncinate process. We put down the mucosa that covers the inferior part of the uncinate over here. And then we drill some bone here anteriorly at the level of the nasolacrimal duct. After this, we smooth all the field around. With this beaver, we make a vertical incision in the middle part of the sac, a vertical incision, in order to open the sac. You see, this is a curved beaver, and now we are opening the medial wall of the sac. We try to make a big stomia in order not to put the stent later on. Nowadays, we try not to put the stent, but to make the stomia more larger. And then a superior and inferior cut posteriorly, and we put the medial wall, we turn it, then we do the same on the anterior part, at the level of the anterior part of the medial wall of the nasolacrimal duct, superior incision and inferior incision. And we try to turn this anterior part of the medial wall of nasolacrimal duct anteriorly. Here we are. In such a way, it is very difficult to have a stenosis of the stomia. Then, as you can see, we expose some bone over here. So this is the flap that we use, we build up at the beginning, and we try to cover in such a way the exposed bone at the level medial to the axilla of the medial turbinate in order to reduce the fibrosis over here. And we usually check what we did. We can insert a probe inside the superior canaliculum, and these we can see very well the common canaliculus outlet over here. So you see this insertion of the probe over there. And then we can put again the inferior flap on the uncinate, covering the inferior border of the stomia. Okay? These are the flaps for the DCR that we usually use. Now I will show you the orbital decompression and the anatomy, how to perform it, and the anatomy of the medial compartment of the orbit, extraconal and intraconal. So we treated yet nasolacrimal pathway, then we move posteriorly, and we use this technique mainly to decompress in Basedov, to decompress the orbit medially, or to get access for the lesion in the intraconal space. And let's keep these beautiful images of Jacopo, Dallan, and let's go to surgery because we don't have too many time again. So here we expose we perform a complete ethmoidectomy, and you need to perform a sphenoidotomy. So you need to remove all the cells here of the anterior posterior ethmoid and to open the sphenoid, opening the frontal sinus, of course. So and the maxillary sinus. So you have to complete your full house fast in order to start the orbital decompression. And so anterior ethmoidal artery over here and posterior ethmoidal artery over there. Then you expose the papyracea. But the most important advice to you in this case is to remove the papyresia. But how to remove the papyresia? The most important thing is not to remove this superior part of the papyresia, where at the level of the natural osseum of the frontal sinus. Because if you remove the papyresia there and you open the periorbit, the fat will close your frontal sinus. And the second important thing is to open the sphenoidal, the anterior sphenoidal wall, and to drill here where there is the crossing of the medial orbital wall, of the medial wall of the sphenoidal sinus, so the lateral wall of the sphenoidal sinus, and the superior wall of the maxillary sinus. Where it crosses, you have to remove the bone over there, because when you have to decompress the orbit, if you don't remove this bone, you cannot decompress the fat in the posterior part of the orbit. You cannot leave the bone over this area. And you can extend the removal of the papyraceal till V2 inferiorly. That is your inferior limit of the compression. So this is V2, infraorbital nerve, sorry, yeah, V2 that becomes infraorbital nerve. And you have to drill in this crossing part of the structures I referred you before, because you need to expose the orbital apex and to decompress the fat on the posterior part of the orbit. And then, you see, this is very important. After you remove the papyraceae, this is the answer of what they answered me last time. How do you open the periorbit? We usually perform 2 horizontal incisions, 1 low and 1 in the upper part, and then 2 or 3 vertical incisions. In such a way, you see, you expose the fat of the extraconal space. Okay. Then it depends how do you want to decompress. At the beginning, you start to push the bar and the fat comes out. If you need to decompress more, you can, with the vial, try to remove a little bit of fat, because the fat has a sort of connective tissue that brings the fat like a intact. So if you want to decompress more, you have to work on the fat. Now let's go inside the orbit, and you can, if you want to remove an extraconal hemangioma, for example, you need to expose the muscles, and you can remove the fat. This is dissection. I want to be clear. We try to remove as low fat as we can when we remove extracornal lesion. We don't do this. We try to preserve the fat, but it is an anatomy, and I want to show the structure that are below. So after you remove the fat, the biggest muscle you have in front of you is the medial extrinsical muscle, the medial rectal muscle. Over here is the biggest muscle that is present in the lateral wall. And then over the medial rectus muscle, in the upper part, we will have the superior oblique muscles over here. You see, middle and superior. Then we remove the fat between these 2 muscles in the posterior part, and we can see over here the optic nerve with the ciliary arteries and ciliary nerves. So pay attention when you have a lesion in the posterior part of your orbit in the intraconal area, because if you use bipolar here in the medial part of, for example, an hemangioma that is located here, you can burn the optic nerve. That's why you see all our videos when we are working inside the orbit that we use cotonoid to dissect the lesion, and we never use the bipolar medial to the lesion, mainly in posterior part, because we have this risk to damage the optic nerve. And then here, ophthalmic artery with these branches that are the ethmoidal arteries. These are ciliary nerves, ciliary arteries, and this is the ophthalmic arteries with all the branches, the anterior ethmoidal artery here and the posterior ethmoidal artery. Let's see the anterior ethmoidal arteries pass between the superior oblique muscles and the medial rectus muscles. As you can see in all the TC preoperatively, you see the anterior ethmoidal arteries coming out, ophthalmic artery over there. And the last, if I have time, 2 minutes, the decompression of the optic nerve.
Thank you.
Do you have time, or?
We have it. It's essential. What I want you to do is to tell everyone where's the exact position where you should perform and open the canal to avoid consequences, please.
Sure. So, as you can see here, over here, we are at the level of the sphenoid, and this is the optic canal, okay? So optic nerve, interoptic carotid cells, and the carotid artery, the paracavernous over here. So we start drilling over the optic nerve, removing the bone of the optic canal. You see, exposing the dura that covers the optic nerve. And then it's very important to extend the removal of the bone toward the orbital apex. So you have, of course, to perform an anteroposterior ethmoidectomy, okay? And all we know that here, at the level of the passage from the orbital apex to the optic nerve, we have a connective tissue that is the annulus of Zinn. This is like a hard connective tissue that is around the optic nerve. If you want to decompress the nerve, you have to decompress the annulus of Zinn, where the extrinsical muscle of the orbit attaches, okay? Because if you don't decompress these structures, you reduce the possibility to decompress the nerve, because you will always have a ring around, and it will be the part where the edema can be stretched by the ring. So usually we start from the orbital apex to have the incision of the guina of the nerve. We can use a small knife, or we can use small scissors. And the important thing is to have the incision superiorly. So you have to prolong this incision here in the upper part, because on the left side you can encounter the ophthalmic artery between 6 and 9 p.m. And on the right side you can encounter the artery between 3 and 6 p.m. So if you have to stay between, on the left side, if you have a clock, between the 6 to midnight. On the right side you have to stay from 1 to 3 o'clock. Is it? Do you understand?
Can you reply that it's essential, because we are dealing with an artery that will compromise drastically the whole thing. So
yeah,
for if you're in the left side, we have to.
Left side. We are on the left side.
Right.
This is 12. Then on the right side we have 3 o'clock, 6 o'clock, 9 o'clock. Okay, you have to perform the incision between midnight and 9 o'clock. p.m.
Perfect. So
because you can get the artery over here. Okay, if you make an inferior incision, you can damage the artery. I will show you. You see, you can open the dura covering the nerve. And let's see where the artery is in the inferior part. Okay? It's very hard it's not possible to find the artery here in the upper part, the medial part, upper. But here, between 6 o'clock and 9 o'clock, you can encounter the artery. So never make this incision inferior. Then, you know, there are different techniques. There is who say you can only remove the bone without decompressing the sheet of the nerve, so without opening the dura that covers the nerve. These are different way to do, but if you want to maximize the effect of the compression, you need to open the dura and to expose completely the nerve. But the most important thing, as I told you before, is to cut the tissue of annulus of Zinn over here. It's very, very important. It's mandatory in order to improve the success of this technique. And with this, I finish my presentation.
Enough for today. I think that's completely done. I'm sorry for interrupting you most of the time, but it's essential because not all of the participants are very trained or advanced surgeon. What we would like to know, for those who don't know, we built this association a few years ago. Paulino was essential part of this association, such as the other participant in this step-by-step anatomical dissection training live. So it's important, the importance of those material and didactical material are essential to let the younger get to a position in which they already know what to do and what not to do, because the importance is what not to do. If you want to do it, if you can do it safely, but you have to understand what the speaker are saying. And in order to do it, the best way to do it is to follow our dissection courses or dissection live courses, such those in Varese and worldwide. And I always suggesting to participate in one of them. Varese is my second home. There's beautiful, there are beautiful, beautiful equipment. You can go there, train. You can see beautiful live cases. So can we now just briefly go into some questions before closing the remarks? Okay, so the first question is this: how far superior can we excise axilla of the middle terminate? Is there any landmark besides the anterior ethmoidal artery?
You can go till the attachment of the at the level of the skull base without risking. Without risk. If you remove the axilla, the anterior wall of the Agarnasi, you can remove it till the skull without problem, without risk, because the skull base will start posterior to the attachment of the middle terminate at the level of the skull. So it's safe, what I show you at the beginning of the building up of the flaps. Safe.
Okay, another question still, removing completely the orbital strut doesn't increase the chance for post-op diplopia?
Removing completely the orbital?
If you remove completely the orbital strut, doesn't increase the chance for post-operative diplopia?
Strut means, sorry? Strut.
I don't know what I think that...
No, I can try to answer. If you remove the papyracia and you open the periorbit and you don't push, you preserve the fat, and you remove the lesion, try not to open too much the periorbit, we usually don't have post-operative diplopia. So we try to open the periorbit at the level of the lesion, try to remove the fat as much as less as we can, and to go directly to the lesion. Usually we don't have diplopia. Of course, if we have to decompress the orbit for a Basedov, we want to put the fat out, and the patient is yet with diplopia, you know.
There's another question regarding when exposing the sheet of the optic nerve, doesn't CSF leak from there?
Yeah, there could be some CSF leak, but you can cover with some mucoperiosteum from the floor of the nasal fossa, or with some tabotap. It will stop. There is I follow a beautiful lesson of Stamberger about this issue, and he says that put some fibrin glue, some tissue, and it will stop. You will not have leukorrhea from continuing from the optical canal. It was the same question that made to Stamberger some years ago. It was,
yeah. And regarding the question that done before was the strut is the bone lining between the medial and inferior bony wall of the orbit. Some authors suggest to preserve it.
We drill the cross part between, we drill. It's Castelnuovo. If you do this and enter in the operating room, start. Yeah, what are you doing? Let's drill there. No. We do it.
We can talk a lot about that, but yeah, there's crazy stuff that you have to avoid when surgery. And I remember one time we were there, and we were in the day surgery. I remember he was doing a draft 3 revision under local anesthesia, and I was like, wow.
Yeah, he liked it.
Yeah. So, thank you, Paolo, for this adventure. Next week, can we assess next week for the flap?
Yeah. Okay.
Okay. So here's the title for those who don't know. It's going to be the whole videos will be based on the septal flip flap, which is a great flap that Paulino developed a few years ago for anterior skull base reconstruction. You will get more information about that. We will put leaflets and information tomorrow, probably the days after, on Monday. You will have all this information. Just a quick reminder, from now on, every one of our meeting will be accessible with the same link and with the same ID. Everything will be easier, so you just can copy and put, and you can access to that. Thank you, Paolo, for being with us today, Saturday.
It's a pleasure.
It's always a pleasure for me to have a brother like you and here. Many other colleagues are following and watching us today. Some of our friends are bringing cheers. So thank everyone for participating, and I'll see you on next meeting. By the way, is going to be on Wednesday. We will have 2 meetings, so keep attention on the Facebook and YouTube pages. Grazie Paolino.
Grazie, ciao.
Buon pranzo a tutti.